So first, I need to start with my required disclaimer, and that is the opinions you're about to hear are mine, not official positions of the National Cancer Institute. Jim Doroshow, one of our deputies, had to leave earlier, but if he were here, he could attest to that. So let me start with some background about screening, and this talk is restricted to screening, not primary prevention that you have heard about earlier in the session. These levels of decision-making were formulated by Leon Gordis, who, as you may recall, some of you may recall, was the chair of the NIH Consensus Development Conference on mammography for women in their 40s. And when he concluded that they couldn't make an across-the-board recommendation for all women in their 40s to get screened, and therefore it was should be an individualized risk-based decision, he was frankly taken aback by the pushback, the anger, and even violent behavior that occurred right after they read the statement. And he tried to formulate in his own mind why that was. And I think he came to a very good conclusion about the formulation. He basically felt that people within the room were operating on far different levels. Level one is what would you want to do for yourself, or what would you recommend for a person in your immediate family. And of course, if you make the wrong decision and you choose something that's harmful, you've only harmed one or two people. Level two is what many clinicians think at, and is what would I recommend to my patient or client. And here again, if you happen to make the wrong decision, it happens to be associated with a net harm, your harm is still limited by the number of people that you can see in your practice over a period of years. Hopefully, nevertheless, this level of decision-making is informed more by personal biases, more by the literature than your personal sense of things and your own personal value system. And physicians are told all the time not to impose their value system on their patients, so hopefully they can look to the literature. But level three is what national programs must rest on, and that is what would you recommend to the entire nation or to the entire world. These are across-the-board recommendations for huge numbers of people. And therefore, if you make the wrong decision here, it can be very costly, not only in terms of dollars, but in terms of human costs if there is a net harm, and it affects very, very large numbers of people. And often panels such as yourself are supposed to operate at this level, and too frequently within panels you'll see people flipping back and forth between the various levels. And so it's at level three that I'm going to give the rest of my talk. There are core issues in screening and prevention, but this primarily in screening, that are often we often lose sight of. First is that it's very difficult to make healthy people better off than they already are. And therefore, strong evidence of benefit is important when putting large numbers of healthy people in harm's way. Unfortunately, even though it is difficult to make healthy people better off than they already are, it's not so difficult to make them worse off than they already are if you have an intervention that harms a substantial number of them. And that's why evidence-based groups such as the U.S. Preventive Services Task Force rely on an analytic framework for cancer screening to avoid all of the mental shortcuts, which are almost inevitable when you're operating at levels 1 or even at levels 2. They remind us in their analytic framework that these are healthy people, and you can't afford a lot of harm to a large number of people. They also remind us that the simple finding of the ability to increase the diagnosis of cancer is only an intermediate endpoint, and other intermediate outcomes are unreliable predictors of what we really are aiming for, and that is health outcomes. And that even includes surgery for cure, or decrease late disease, or an increase in early stage disease. Unfortunately, most, if not all, screening tests will fulfill those intermediate endpoints, even if they confer a net harm. But what we're looking for is a reduction in cancer mortality, overall mortality or quality of life. We also need to know and articulate to the public what the adverse effects of screening are and the adverse effects of treatment. If we don't convey them, then informed decision-making is impossible for the patient or participant who's considering screening. And finally, more and more, we're coming to realize that we have to think at least about societal incomes and trade-offs, and this was the substance of Lee Newcomer's talk today. Sooner or later, if we haven't already reached it, we are arriving at the day of reckoning, because you can actually diminish the health of the community by diverting resources from things that work a lot to things that work a little, or even worse, diverting resources from things that work a lot to things that don't work at all or have a net harm. And there have been national experiments, unfortunately, where we have done just that and spent an awful lot of money and not to the benefit of the health of the population. So Muir Gray summarized this best when he said all screening programs do harm. All screening programs do harm. The public doesn't know that. All screening programs do harm. Some do good as well, and of these, some do more good than harm at a reasonable cost. So he covers the entire analytic framework in one sentence. So I'll go over the consequences of screening, and there are good ones. I don't want to undersell them. As a matter of fact, we all assume there are good ones. The assumption that screening tests are good are actually coded in the DNA of our belief systems. They are imprinted in every one of our neurons, and by that I include the amygdala. But just for the sake of completeness, I am going to give you the two benefits that we know, potential benefits. One, of course, is reduced risk of death from the target cancer compared to no screening. Ideally, it would be reduced risk of death, period, because ascertainment of cause of death can be rather subjective, and you can actually increase the risk of another cause even if you decrease the risk of death from cancer. There are a whole variety of diseases that we can trigger because of the toxicity of our interventions. And since the balances are often close, you usually need a randomized controlled trial to determine this, unless the benefits are absolutely huge and the harms are minimal. And then this is a side benefit, at least for some people, and that is reassurance. But this assumes, of course, that healthy people need reassurance. It turns out that most healthy people are healthy. It's only the minority that are not healthy, and so a negative screening test actually doesn't add that much information using the Bayesian theorem or the Bayesian formula when you tell a healthy person that the test is negative, so they are healthy. There are also consequences of bad, and we don't do a good job at studying them, reporting them, or conveying them to the target population. There is follows: false reassurance when you actually do have cancer, false alarms, a lot of false positives, and the harms of an unnecessary workup. And this isn't just anxiety, but these can be some invasive tests, but even the anxiety can last a long time after a positive screening test. Harms of the test itself: bleeding, sepsis after biopsy, admissions to the hospital or admissions to the emergency ward because of a complication of an invasive screening test. Detection of a lethal cancer without changing the outcome. This is actually pretty frequent. Most of the cancers that we pick up, we don't change the outcome. If it's a highly lethal cancer, then we haven't changed the outcome. Certainly not if it's already metastatic, and so we have little ability to change the outcome there. And that's why when you look at the efficacy of most of our screening tests, you're not talking about 80% reduction in mortality, 90%. You're talking about 10%, 15% relative reduction. However, if you're diagnosed early, you spend more of your life as a cancer patient, even if you're going to die on the same day of the same cause. And then finally, detection of non-lethal cancers, and this goes under the moniker overdiagnosis. We are learning more and more that there's a very broad spectrum of natural behavior of cancers, and the more sensitive the screening test, the greater our ability to pick up those very, very indolent cancers, and some of them are not destined to cause medical harm unless you actually detect them, and they are not likely to shorten lifespan. However, an overdiagnosed patient is a cured patient. An overdiagnosed patient is a long-term cancer survivor. And so you have a lot of the downstream effects. First of all, there's no negative feedback loop. A person who's been overdiagnosed feels that they have been benefited, and this leads to a circular reasoning. And we don't do a good job of reporting the harms, as I mentioned. A recent literature review, papers published 1946 to 2012, reviewed reporting of harms in 57 randomized trials of 10 technologies. Only 2 quantified false positives. Only 4 went over the issue of overdiagnosis. Negative consequences were reported in 5, invasive follow-up procedures in 27, all-cause mortality in only 37 of the 57, and withdrawal due to adverse effects 1. This is just poor reporting. So it's impossible for the health professions to discuss with a patient the balance of benefits and harms if they don't even know it, if it hasn't been reported in the literature. So what can we do about cancer? And so I'll have to point out that there are only 3 types of federal employees, those that can count and those that can't. And so here are my 3 proposed new directions as per our instructions. One is to educate people about overdiagnosis or all of the harms, because the public can't make a decision unless they really know. We need to talk to the media about this, because they are the honest brokers. They transmit the message from over-enthusiastic medical scientists to the public, and they have to understand how to transmit it. And of course, health professionals who also are not trained in this. We have to think about changing the terminology. The term carcinoma is frightening. So when we talk about ductal carcinoma in situ, that can pollute our thought, and thought corrupts action. And it's very difficult to think that maybe you shouldn't do anything if the word carcinoma has been applied to you and you're now a patient. Prevention, there are ways to prevent overdiagnosis. One is better education about whether the screening test works at all. But there are other examples, maybe not the best, but finasteride seems to decrease the risk of overdiagnosis, even if it doesn't decrease the risk of life-threatening prostate cancer. But at least there are strategies we can think about limiting overdiagnosis in people who want to be screened. And then finally, research targeting the underlying biology. If we don't understand better than we already do the molecular patterns of those lesions that are dangerous and must be treated after screening, and those that are best followed and watched, then we're going to be stuck in this box. And this is one of our major new thrusts at the National Cancer Institute and in my division. Thank you.
Thank you. Our next speaker is Lily Shockney, who is an administrative director at Johns Hopkins University, and she is not only that, but also an activist and an advocate.